So I will be talking on liver transplantation for cholestatic liver disease, timing and disease recurrences. So I will be covering this topic under the spectrum of cholestatic liver disease, PBC, PSC. What causes fibrosis in cholestatic liver diseases, epidemiology of these liver diseases, define optimal timing for liver transplant and PBC, PSC, secondary sclerosing cholangitis or genetic cholestasis. Integrate meld sodium, and as the meld and meld sodium underestimate cholestatic liver disease, so there are different scores, other scores which should be taken into account. We will be talking about them also, and exception points which the PBC and PSC receives. Review outcomes and recurrence, post-transplant recurrence are seen in patient with PBC and PSC. We'll be discussing about those also, and the strategies to preserve the graft survival. So spectrum of cholestatic liver disease include PSC, which is a large or small duct, which has a high IBD association, ulcerative colitis predominantly. PBC, they have MA positive and PBC specific ANA like glycoprotein 210 and SP100 are positive. They have a variable UDCA response. Secondary sclerosing cholangitis include ischemic critical illness related infectious, predominantly HIV, post-surgical IgG4 related, and there are some genetic fake ABCB4 Alagili syndromes. So if we see the location of injuries due to these cholestatic liver disease, they can be you can see on the intrahepatic cholestasis, they have a viral brick PFIC Alagili, and they predominantly affect the transporter and sarcoidosis and they are extrahepatic diseases which include the PBC, which include the PSC, which is a larger disease, and the PBC can have the small disease. So difference between the PBC, PSC and the genetic cholestasis is the inflammation. In the PFIC or other genetic cholestasis diseases, there are less inflammation, but the PBC and PSC, there is a high inflammation which causes the fibrosis and eventually cirrhosis. Multiple pathways are involved like NF kappa beta, TLR, TNF alpha, TGF beta signaling, chemokine. Notch pathway is important. In patient with hepatitis A causing cholestasis, there is a expansion of the Notch pathway which causes cholangiocyte transformation, and that is why the hepatitis A patients have cholestasis because of this Notch pathway. NLRP3 inflammasome and bile acid receptors, which include FXR, vitamin D receptor, pregnenolone receptor, and retinoid organoid receptor. So what causes the fibrosis, inflammation, and the cholestasis? So we see the inflammatory infiltrate in PBC and PSC starts from the periportal area. There are portal myofibroblasts which are activated first, which causes periportal fibrosis in PBC, PSC, and thereby the periportal and eventually the lobular inflammation which causes fibrosis. So inflammatory infiltrates are released, which releases the profibrogenic mediators, and which in turn stimulates the cholangiocyte epithelial mesenchymal transitions and arrangements of the epithelial mesenchymal transition, which stimulates the further chemokines and the cytokines, which further causes ductular reactions. And in the ductular reaction, there is a proliferation also, and there is a cholestasis also, because they are not synchronized, so which further causes cholestasis. If we talk about the predominantly PBC symptoms stratification and the timing for the liver transplant predominantly, and in the demography, we see PBC has a pooled incidence and prevalence increases with the age, and it is reported at 1.76 to 14.6 in 100,000 in population. And in a study which showed that they took 308 patients, and elderly more than 55 years and the young patient, and they showed that younger patients were predominantly affected with the PBC and carried higher mortality and decompensation, while the older people, they died because of the other causes apart from the liver failure. In the gender, there is no predisposition or there is no specification for the male or females. In PBC, the wait list outcome as compared to the alcohol NASH viral hepatitis is very high. The hazard ratio 1.45 despite the post-transplant survival. And if we see the trajectory in PBC, there is a 22% increase in the waitlist mortality per 5-point increase in MELD score when we compared these with the alcohol liver disease, 5-point, and the NASH. So PBC carries the highest waitlist mortality. PBC with the MELD more than 30, they also carry the high 90-day mortality, and they have very low 90-day transplant probability because they die during the waitlist mortality as compared to the other non-PBC causes, predominantly ALD, they have taken into account. So what are the scores which are to be considered for deciding which patients can be taken for the liver transplant? They are Mayo risk score, which includes age, bilirubin, albumin, prothrombin time, edema. The important score is GLOBE score, which includes the age, which is is also a prognostic factor. Lower age was carrying poor prognosis, higher bilirubin, ALP, albumin, platelet count. And in this study, 1100 patients of UDCA treated PBC were taken from the 7 centers, and they had a median follow-up of 7.6 years, and they showed that when they compared other score like Mayo score 1989, 1994, MELD, UK PBC, they showed that GLOBE score, which include age, bilirubin, ALP, albumin, and platelet count, perform better in the multivariate analysis also with a hazard ratio of 2.36. So we should take the GLOBE score into the our clinical side also to see the PBC patients and prognosticate them according to it. Apart from these scores, what are the other parameters of disease severity in PBC? So the symptomatic, the patient developed pruritus, that is also a poor prognostic sign. Pruritus develops in 70 to 80% of patients of PBC at some point of time, and only 25 to 40% responds to medication. So rest of these patients, the patient who is developing pruritus or the patient who is not responding to UDCA carries poor prognosis and a high chance of mortality. PBC specific antinuclear antibodies against GP210 and SP100 antigens, they also carried higher mortality. ELF, high ELF at the baseline, and if the 1-point increase in ELF in PBC, it carries a 3-fold high mortality. LSM, we need not to see the 15 or 20. If it is more than 9.6, then in PBC patients, then also it carries a high risk of, it should be considered into the high risk category and should be monitored frequently, and they can have the poor prognosis. In the biopsy, if the degree of lymphocytic interface hepatitis is high, ductopenia is there and fibrosis is there, that also carries very poor prognosis and mortality, and of course HVPG, which is higher portal pressure. So what is the indication of liver transplant? If we see the trend from the USA or Europe, there is a decrease in the transplant indication in the PBC because of the better medicines like UDCA, obeticholic acid. So in the Europe also and the USA also, and but we advise as per the MELD score more than 50, which in every case we advise for the liver transplant, but in cholestatic liver disease it underestimates. So we have to use GLOBE score, UK PBC or other scores. Bilirubin ranging from 3 to 5, there was a, according to EASL, they should be advised for the transplant in the PBC patients 3 or 3.5. Very earlier, Shapiro et al., they showed that if the 2.5 milligram per deciliter bilirubin is rising per year, it carries a very poor prognosis and should be advised for the transplant, at least waitlisted. Intractable pruritus refractory medical therapy are also an indication of liver transplant in PBC. If we talk about PSC, so burden is variable and the highest incidence is seen in North Europe and North American and lowest in Mediterranean region. If we compare from the PBC, the PSC transplant wait listing and listing is higher in PSC as compared to the PBC. So data from the European registry showed the increase in PSC related liver transplant rising from 3.2 to 4.5% of all transplant indication in Europe as well as in Canada. So, and if we see the wait list mortality, usually the mortality in these patients is because of the recurrent biliary obstruction and the cholangitis. And despite potentially longer wait time, the time of death or waitlist removal in PSC patients is not higher. What it means is that patient with PSC and non-PSC patients, PSC patients can live longer with the bacterial cholangitis and biliary obstruction, which can be taken off with the endoscopy and other medical therapy. So they can stay for the longer time in the waitlist criteria, and they are usually withdrawn from the waitlist if they develop infection or cholangiocarcinoma or colorectal cancer. So, but the biliary obstruction and cholangitis are the predominant indication for the transplant in PSC. If we look at the scores like Amsterdam model, which includes the age at PSC diagnosis, albumin, bilirubin, AST, ALP, platelets, and also whether the disease is small duct or the large duct. It stratifies the patient into the high risk and low risk. Similarly, revised Mayo score, Presto score, and UKPSC scores, which include these criteria, they can modify or stratify the patient into the high risk and lower risk, and we can further explain them. So what is the indication of liver transplant in PSC? PSC with cirrhosis, of course, with the portal hypertension is a indication for transplant, but PSC with a hilar, cholangiocarcinoma after Mayo protocol, recurrent bacterial cholangitis, cholestasis causing refractory pruritus, weight loss, and metabolic bone disease are also an indication for the liver transplant if there is no portal hypertension. So without cirrhosis also, patient having recurrent bacterial cholangitis, they should be advised for the liver transplant. Pre-transplant optimization is necessary as in all cases like infection control, culture-guided antibiotics managed. We should manage them with the, if there is a dominant stricture, ERCP should be done and the biliary drainage should be achieved. We can do the balloon dilatation, but the contrast is should not be instilled in some cases. Nutrition should be high protein, fat soluble vitamins, because cholestatic liver disease, the fat soluble vitamin deficiency is noted. And bone health, we should vaccinate them with the hepatitis A, B, pneumococcal influenza, HPV in the females, and IBD screening is very important. I'll come to it in details, because achieving mucosal healing, if we go for the liver transplant with active IBD, then there are high chance of recurrence of PSC in post-transplant. So, and apart from that, apart from the ulcerative colitis IBD, we have to also screen for the malignancy and colon cancer, which can be associated with the PSC. So colorectal surveillance and the colonoscopy is mandatory. If we see the transplant is done now, the post-liver transplant cholestasis, which can be seen in these patients. So every post-transplant cholestasis cannot be a recurrence of the PBC or PSC. So they can be early presentation, late presentation. Early presentation can be the surgical, like ischemia, reperfusion injury, bile leak, small for size graft. Vascular causes can be hepatic artery thrombosis, stenosis, and anastomotic stricture. Infections can be bacterial cholangitis, CMV, which can be associated with a higher immunosuppression. The CMV can be seen. Sepsis, immune-related or infection-related are very important causes of cholestasis in the post-liver transplant period. ACR, acute chronic rejection, can have cholestasis symptoms also, and the toxic drug-induced liver injury CAM intake. Late presentation can be immune-related, like recurrence and chronic rejection, non-anastomotic stricture. In the chronic rejection, patient usually can be presented with only pruritus. So the chronic rejections should be suspected in patient with post-transplant and having pruritus. ALP, GGT should be seen, and there should be MRCP and further investigation. Vascular cause late are rare, but can be seen with the stenosis part, not thrombosis. Obstruction like bile duct filling defects, stones can be seen in the post-transplant period. So and toxic drug-induced can have DILI can present in the early also and the late also. So what are the diagnostic criteria for the recurrence of PBC post-transplant? For the PBC, patient should have been transplanted for the PBC. There should be presence of anti-mitochondrial antibody. Other causes should be ruled out, and the liver histology like mononuclear inflammatory infiltrates, formation of lymphoid aggregates, epithelioid granuloma, and bile duct damage. It is a definite recurrent PBC if 3 of the 4 portal tract lesions are present, and probable if there are 2 of these 4 are present. Recurrent PSC, of course, the confirmed diagnosis of PSC before transplant, and intrahepatic or extrahepatic biliary stricturing, bleeding, irregularity more than 90 days after liver transplant, or fibrous cholangitis or fibro-obliterative lesions with or without ductopenia, biliary fibrosis, or biliary cirrhosis. There should not be hepatic artery thrombosis or other causes which can cause cholestasis which can be seen, or infection to diagnose recurrent PSC. So what are the risk factors for recurrent PSC? So PSC, they can be extremes of recipient age, old age, younger age, advanced disease, MELD more than 24, coexistent IBD diagnosis, active IBD, ulcerative colitis at the time of liver transplant, biliary complication developing within 1 year after liver transplant, severe cholestasis within 1 year, IgG4 tissue positivity on explant, pre-transplant cholangiocarcinoma. There are some donor risk factors like donor age advanced, prolonged cold ischemia time, extended criteria donors, liver recipient sex mismatch, liver related donor, and the immunological factors like presence of certain HLA haplotypes, use of intensive immunosuppression like tacrolimus uses. I'll come to the immunosuppression in detail, and for the refractory, multiple episodes of ACR can also cause a recurrence of the PSC. In the PBC recurrence, younger age PBC diagnosis less than 50 years, younger age of LT, early biochemical cholestasis after liver transplantation, elevated IgM, AH, PBC overlap, or presence of the anti-mitochondrial antibody. If there, then the chances of recurrence of PBC are there. Younger donor age, recipient donor sex mismatch, prolonged cold ischemia time, and use of tacrolimus higher. So in the recurrence of PBC, we advise that the patient should be off tacrolimus in the after the 6 months. They should be switched to cyclosporin, predominant immunosuppression as compared to the tacrolimus. Multiple studies have advocated that the tacrolimus in prolonged can cause recurrence of the PBC. Because they cause ductopenia, tacrolimus. What is the impact of IBD on recurrence of PSC? So there is a meta-analysis of 2059 patients which showed a higher risk of recurrence of PSC in patients with IBD. Active colitis and de novo colitis after liver transplant have been identified as independent risk factors of the recurrence of PBC. You can see the hazard ratio is 1.73, and in the right side, which showed that presence of IBD or colitis can cause recurrence of PSC in the future. Colectomy before liver transplant. So this is a meta-analysis which favors that colectomy if the active disease is there, UC is there, and we do colectomy before liver transplant. That is protective of recurrence of PSC. But fewer studies have recently come, but they showed that unequivocal. They do not say that colectomy can be safer or not. But this meta-analysis favors that colectomy before liver transplant can protect in development of recurrence of PSC in the future. Cholangiocarcinoma before liver transplant. In the same meta-analysis, they showed that the presence of cholangiocarcinoma is a risk factor to develop recurrence of PSC in the future. Other cholestatic diseases include secondary sclerosing cholangitis, IgG4, which ensure adequate. They have IgG4 related secondary sclerosing cholangitis respond well to the steroid and azathioprine, also rituximab, if they are not responding to the steroid and azathioprine. Genetic cholestasis, PFIC or ABC, they progress very slowly to the fibrosis or cholestasis, mainly because of the bile acid, because there is no inflammation or minimal inflammation. So if there is no inflammation, then the fibrosis and the cirrhosis is less chances to develop in the future. And so again, the recurrent of PSC presentation can be cholestatic lab based. So we have to see for the liver test like AST, ALT, ALP, GGT, and if they are raised, and then we have to order for the MRCP, and multifocal bleeding or the single dominant lesion is there, then we can do endoscopy and drainage of the bile, and thereby improving. And if the drainage is not possible by with the single dominant structure, then we should perform the biopsy, and it can have recurrence of the PSC. Risk factor again same, young age, active IBD, and outcomes can be cholangitis, graft, fibrosis. Recurrence of the PBC is rising ALP. In the biochemically, you should suspect recurrence of PBC if there is rising ALP and GGT in the post-transplant period. AMA persistence is noted, and the florid duct lesion on the biopsy. Risk factors are lower immunosuppression in the initial period. They are usually mild to moderate, and they impact the long-term graft survival. Management is UDCA, which I'll discuss again, and the early biochemical detection enables the medical control, which is important. So this is a preventive UDCA. This study was done in the post liver transplant patient. 780 PBC patients were transplanted from the 16 centers and 11 years follow-up. They used preventive UDCA, and they showed that it was associated with the reduced risk of PBC recurrence, graft loss, and all-cause death. Exposure to cyclosporin rather than tacrolimus has a complementary protective effect alongside UDCA. So cyclosporin along with UDCA in patient transplanted for the PBC usually have the favorable outcomes. So in the this graph also, the follow-up years without preventive UDCA and with preventive UDCA, they performed good, and the incidence rate of the recurrence PBC was lower in patient with the with preventive UDCA uses. So what is the immunosuppression studies? Immunosuppression strategies like calcineurin inhibitors are the backbone, like cyclosporin, tacrolimus. Cyclosporin should be preferred. MMF or mTOR to balance cholangiopathy risk and then nephrotoxicity. Steroid should be tapered, but in the low dose can be continued if there is no infections. Infection prophylaxis and the vaccinations are very important in the PBC or cholestatic liver diseases, including hepatitis A, B, and the shingles. Drug monitoring with the tacrolimus level and the cyclosporin level is also important. It can cause the tacrolimus high dose can also cause cholestasis, and the cyclosporin high dose can also cause cholestasis. In PSC, there is high chance of the colon cancer, so surveillance is important with the MRI, MRCP, and CA19 protocol, and LT for the perihilar after the Mayo protocol, and cancer surveillance with the colonoscopy and the skin cancer screening also very important. Pediatric to adult transition for the PFIC and ABCP4 is also important, because many patients are, if there is no transition, then the care can be hampered. So that the graft functioning should be taken care of, and the genetic counseling and other thing has been done, but they should be properly followed if there is a transition for the genetic cholestasis diseases. If we see the future idea, then PSC microbiome, bile acid, mucosal immune axis should be explored, because it is an inflammation based disease. FXR PPR agonist, antifibrotic in pre and post liver transplant, they have been tried in the pre-transplant setting only. No study of FXR or obeticholic acid has been tried in the post-transplant. There is no study. UDC has been there, but obeticholic post-transplant has not been tried. Biomarkers we can explore with the donor-derived cfDNA, bile, serum, proteomics to identify the early PSC and as well as the early PBC recurrence to predict these patients. Long-term follow is important because of the quality of life, because these patients develop the pruritus and the fatigue, and the subsequent portal hypertension. So we have to see. Monitor with the bone health, because fat-soluble vitamins are not absorbed in the cholestatic liver disease patients. So we have to supplement with the vitamin A, D, E, K, and the cancer screening is must for the PSC. Vaccination booster doses are important apart from the normal vaccination schedule. So to summarize, cholestatic liver disease in pre-transplant setup, we have to assess for the symptoms burden like jaundice, pruritus, fatigue, recurrent cholangitis. We have to assess with the risk scores for the Mayo risk, PBC Mayo risk score, Globe, UK PBC, and for the PSC like MRS, Amsterdam, or UK PSC score. MELD has limitations, so we have to consider the exception points, also the other scores. Malignancy risk is very important or very high in the PSC patients, so we have to see for the cholangiocarcinoma and colorectal cancer. Peri-transplant, we perform the LDLT, DDLT is not there, so they have a higher rejection risk, so higher immunosuppression is needed during the initial part. Recurrence is high in the PBC, it is 22 to 50%, and then PSC it is 15 to 30%. So very high recurrence, 1 in 3rd or 1 in 2 patients are recurring, so they should be carefully monitored and followed in the OPD. Post-transplant PBC, UDCA prophylaxis can be given, and tacrolimus or cyclosporin should be given with the MMF. PSC control IBD colonoscopy every 1 to 2 yearly. With the active disease, there can be chances of recurrence, so it is very important to screen these patients with the colonoscopy and monitor the recurrence, malignancy, biliary complications. That's all. Thank you.